Good morning.
This was one case which I was in the loop all the time, helping him as a emergency lined up. And this is one situation we were able to diffuse the crisis, even though the outcome was not good from the patient point of view. But from the patient point of view, the outcome was good. And now, after 5 years, the patients attend, family do come to the clinic for their eye checkup. So it is a good outcome. But for the patient, yes, we lost the patient, but there is a lot of learning from the incident. So the entire idea of this instruction course is to take you through area where we are not trained for. One, second, how to prepare for it, how to assess the patient, and how to have the equipments, as Dr. Jayanthan mentioned, and what are the standards the accrediting agencies expect from the eye care practitioners and eye care hospitals, so which Dr. Gagan has put up. So what happened, Dr. Atik has really mentioned about the uh, assessment and having a company for your practice. So what happens if all these things doesn't go as planned and we are in a different situation, so where there is a crisis, if there is a death or there is a unfortunate outcome, so we need all these societies to come and help us. So how do we go about and what do we do? So this is a golden hour situation. In MI, the first 1 hour is called as golden hour, and in RTA or road traffic accident, the patient has to reach the medical care facility within 1 hour. And same way, if there is attack or if there is a unfortunate event in your hospital, the first 1 hour is very, very important. How you shift the patient to another hospital, how you your team takes care of the people, family, attenders, how you break the bad news to the family. All these things are really important. How we document. So this is a pressure cooker kind of situation, and of course, if the pressure cooker situation goes out of hand, we have to go and tackle these kind of the 4 P's: the press, police, political splinter groups, and of the public. So these are some of the important things that have happened. And gone are the days when patient accepted as gods. Now the roles and the letters are reversed, and so we have to deal with this non-medical issues as well in our practice. So we are blamed for every disaster. Like the previous case where the incident was a medical, the patient had an aneurysm, so which is totally out of our hands, and then we are blamed for every disaster. So there is attack on staff, hospital, doctors, and of course the image get dented permanently. So how do we go about this? So crisis in non-ophthalmic emergency situations can be so many can happen due to so many situations. It can be structure induced, where there is no oxygen, where there is no emergency team or emergency equipments. It can be process induced, the staff not doing the work properly or not transferring on time. Doctor induced, maybe non availability of doctor or anesthetist. Staff induced, they give some wrong information to the patients or their attender. Can be drug induced, like what happened in the xylocaine anaphylaxis. It can be self-inflicted or patient or family inflicted. So we have to deal with this diverse kind of non-ophthalmic emergency situation. So as an ophthalmologist, so we should not take over and above our capacity. So you can't deal every situation, every case. So you have to refer at the right time. This is the message we want to give to. So you have to take as per your infrastructure, as per your training, as per your experience. If it's not in your specialty, please be kind enough to refer the patients. Counseling and communication, if you are tackling a patient with comorbidities and multiple uh, emergency situations or critical eye disease, you have to convey the information to the patients properly, document it, have proper communication and consent, and have a maybe you can record the consent videographically as well. As staff induce, the staff not complying with the instruction, wrong site, wrong route, or wrong drug, and rough handling of patient and relatives, and wrong news or exaggeration or spilling the beans what happened in the OT or in the block room. So these are things that can happen. So we have to train our staff to manage the situation. And as I said, the complications of local anesthesia can happen due to various issues. So having a medical person assess this as well as anesthetist assess this and help us really helps. So life is not about how hard of a hit you can give, it's about how many you can take and still keep moving forward. If already we are prepared for it, we can take some more and we can keep moving forward. So how do we face the crisis and how do we prevent the crisis? So in risk management or crisis management, prediction and early warning is important. So you have to be prepared and also try to prevent. So you have to be ready, your people have to be responsive, and we also need to be a bit resilient. So all these things can happen in practice. Practice is not like the previous era. So we have to be prepared and we have to progress with all this in mind. And also you have to bridge the gap with the community. So how do we do this? These 4 P's are important in a crisis management: police, press, politicians, and the public. So liaising with police. So you are running a community practice. So we have to be working with the community at all levels, particularly the law enforcement authorities like police. So this is one situation we came across as a IMA office bearer, death in the hospital. The mob demands 304A and arrest of the doctor. So the local inspector was politically oriented. So he goes to the doctor's house. We got a call, and so 4 or 5 of us gathered at the hospital and protested and called the DGP of police and ensured that the doctor was only given a memo and not arrested. So the issue was solved after that with the intervention of higher officials. Liaison with the press is also important. Local police press people. So if there is a on-table death or if there is a incidents in the OT, this can go out of our hands. So we have to work with the associations as well as the local IMA. And so instead of the doctor talking to the press, we took the initiative, the office bearers, and we talked to the press and explained that this can happen in hospital setting. On-table death or on-table incident or MI can happen in any situation, and the doctor has taken the or provided the patient care very well by shifting. The third important thing is the local people, the politicians or the local areas. So there can be some splinter political group which is spearheading this movement. So we have to talk to them and diffuse the situation and take the help of the other people also. So public relations, when you are running a practice, is very, very important. If you are a small practice, you have to take the work yourself, or if you are running a hospital, you can hire a PRO or appoint a person who is in charge of taking these 3 important P's when they come to our facilities. If the police come to our facility, or the press people, or the political people, so we have to take care of them, because they will take care of them during this kind of emergency situation. So professional bonhomie is very important. So we have often heard of professional jealousy and jostling. So always never talk ill about your professional colleagues in front of the patient. So even though the patient was not managed well, so you have to work in the, so do take care of this important aspect. Join associations, collaborate and work together. So you may be practicing, or it may be a professional competitor, but once you join association and collaborate, so the work becomes easier and we can refer the patient to him or her for support. Process and protocols are very, very important. These are important standards which can prevent such attacks as well as crisis. We can also learn from post-disasters. So this is what we learned from Kumaran's incident. So post-disaster, we have to document this and see where it went wrong and take a proper response, see how we can reconstruct things from then on and move on. So preparedness is very, very important. Prevention is all the more important. So need of the hour, apart from profession, be active like an entrepreneur, be an association member and leader. So again, the problems are not stop signs. They are guidelines for our future practice. So thank you so much for your kind attention. If there are any questions, we have some more time left. We can take questions.
Sir, actually there's a question in my chat box. I think few of them are still in the webinar mode.
Oh, okay.
So they asked what will be done differently for a camp patient? Is it safe to operate them without attenders? When we should avoid operating without attenders?
Okay, so the wants to know about the consent for the camp patients.
So camp
Because
patients
you
usually they bring them without attenders.
Yeah.
So the question is like, is it safe to take them without attenders? And is there any condition where we need to, I mean like, not to take a patient?
Okay, so few important aspect in camp patients. So most of them come with their family members or neighbors, right? So if the neighbor is there, we can get the witness signature from them. Now obviously most of these patients are adult patients, they can give their consent for a local procedure. So the consent is not the issue. If something untoward happens to these patients, whom do we contact? So we have to take the contact numbers beforehand, address. So this is where proper registration really helps, or taking a government ID proof helps. So this is for identification as well as conveying the bad news to the patient's family. So proper registration is important. Very often we see in camp situations, we just take the name and take the patient immediately for surgery without properly assessing. Assessment is one important process, right? So very often we are focused only on ophthalmic assessment, pre-operative assessment, but diligent general examination is also essential. At least the AOS guidelines mention about blood sugar, ECG, and blood pressure monitoring, and monitoring the vital signs during the surgery. So a good pre-operative assessment and intraoperative monitoring is also important.
Please.
You have mentioned about the medical legal cases. Since we are daycare surgery, sometimes we need to refer the patients immediately. So in this case, do we need to give the medical report when asked for, or we can just refuse?
Okay, so what happens in Karnataka is you can maintain an emergency register and accident register, right? Certain cases are clear cut. Like for us, we get lots of these industrial patients, industrial trauma and all. So they are straight of MLC, even whatever they say. So situation where MLC has to be done, it has to be done. Then there is no discretion for you. But in other cases, like you are saying, you have just attended and referred. So you have to still maintain an accident register entry, which basically what Sir was highlighting, that in an accident register, you jot down the injuries, what you have seen, what were your findings, identification marks of the patient, what is the brief history, what accident happened, who has come with the patient, and most importantly, their contact details. So the information which we gather in an MLC, you need to gather that information and keep it. Don't inform the police. Have that information. In case it comes to you, you will have it. Right. The problem is, what I feel is most of the medical legal cases will come early. These RTA cases are having a problem. You're getting summoned after 8 years, 6 years for compensation. And if you don't have a record, you cut a real problem. So the lag period is quite some much at courts. So no one will look at that why we need to keep a record for 8 years. But RTA cases after 6 years, 8 years, 7 years, they're asking for documents and everything. And you would have just done a polytrauma eye examination. So they want a specific report what was the eye part, and though the patient has been managed by orthopedics and other things also. So wherever it is there, keep your record. In case it's required, it's there with you. If not required, then life is good.
Now there are guidelines for keeping the records. For inpatient records, you have to keep for 6 years. And after that, you can, if it's a manual record, you can have a soft copy and continue to maintain it. So particularly MLC cases, whether inpatient or outpatients, where you have a suspicion that this patient had a poor outcome. So these kind of cases, you have to maintain the document for some more time.
Because the courts are condoning that period.
That's there was a time limit, but unfortunately
they are
now
condoning that. So that is what happened. So this case is actually after 7 years. So that's a problem there.
These are the guidelines given by the Director General.
Yes, sir.
Okay, but the courts, as usual, they are taking upper hands
Yes,
and
sir.
revising all the statutes. So the lot of judgments have come that you have to keep all these records for lifetime. We don't know whose lifetime, whether patient's lifetime or our lifetime. Yeah.
I don't know whether it is under the scope of this discussion, but what kind of insurances we should have for a safe practice in for hospital? Like different kind of insurances come on like nowadays.
No, different type
Okay.
means the basic insurance policy is the same. And when you're buying it through certain platforms, they offer you certain extra services. Is that what you're asking?
No, in professional indemnity, so there is a professional indemnity policy available with Oriental Insurance, and most of the PSU companies offer that. So you have to take as per your age, as per your critical nature of the practice. So if you are a surgeon, ideal to have at least 1 crore policy now. And of course, also have this PPLSS scheme or something given by AOS or National IMA or your state IMA, at least for the maximum. I think the maximum they give is for 20 lakhs. So they help us with if you receive a court case or a notice, they help us with guide us with giving a reply to the notice or attending the summons. Whereas the insurance companies will not do that, will not give any medical legal support. So they will only, if there is a compensation, they will pay for as per their policy requirements. So it's always prudent to take this twin prevention. Okay, take maximum policy or insurance indemnity with the PSU companies, and also have insurance or some professional indemnity with the associations.
There are some companies who provide you the forensic as well as the lawyer, and they compensate for it.
Yeah, there are medical legal companies coming. The IML has come with one initiative. So there are companies available, support system is available, but they come with a cost.
Yeah. So
Right.
the one thing, what his question is, the basic professional indemnity is a fixed cost. You can take it from any company. So when you are going through this platform, they give you the basic policy plus whatever their add-on features are. So it's like a car insurance. You can choose any number of riders and add-ons. So up to you and your comfort level. And probably I see lots of variation there region-wise, because ultimately if you are having issues, they will start from your local court to your state court and all. So whatever is happening in a particular state and particular city is actually a good practice to follow. So what is happening in Bangalore will not happen in Mumbai.
Okay, yeah, last question. We have to wind up the session.
I work in a small town, no? So we have an eye center where we all the facilities, but we do not have the infrastructure outside. So like the anesthetists, only 2 are available, and they are in the government setup. So they're always busy in the government work. So I do not have access. So till now we've been operating without an anesthetist standby and haven't faced such problems. But do you think we should continue like this, or like what would be the way to go?
Right. So if you don't have access to anesthetist or the trained manpower, so you have to train your own people. So that is where all this BLS training really helps. So BLS as well as advanced life support. So you have to train your core medical team with BLS and ALS, advanced life support training, and also have infrastructure. So you can't have anesthetists all the time, right? So even in OP this can happen. But you ensure that your people are trained and you always have a trained team available to support you.
So and one more question, can I give anxiolytics routinely before the surgery to all my patients?
Yes, in oral form you can give, but you have to do a proper assessment of the patient, preoperative assessment. See whether the drug can help him. If it's an elderly patient who is very anxious about surgery, you are justified. You are basically a physician, right? Only then you have taken an extra course and become an ophthalmic surgeon. So you are well within your rights to give a anxiolytic. So if you feel that patient is very anxious, you can give.
And so if the blood pressure is high on the day of the surgery, in spite of all the medication, if it's like borderline high, can I treat the patient?
Yes, definitely.
Can I give the antihypertensive?
Blood pressure you can treat, anxiety you can treat, at least for the initial level. So obviously beyond your control, you have to refer the patient or postpone the surgery, ask the physician to control the blood pressure and the other comorbidities, and then refer back to you. So don't hesitate to postpone the surgery. There are people who hesitated and ended up with complications.
Thank you, sir.
So is mandatory to do a skin test for every patient with
No, there are no guidelines as such. It is a risk-benefit thing. You have to take a call based on so if there is a previous history of reactions to any drug, you are justified in giving it. So it's only a documentation